Hello, good afternoon. This is Dr. Velma Scantlebury, and I am the medical director for Dialysis Patients Citizens Educational Center. And today is Wednesday, and this is our usual time for a Facebook Live where I get to answer your questions. So if any of you are out there, please go ahead and join. Welcome, Nancy. Thank you for joining. Appreciate your presence. Again, this is Dr. Velma Scantlebury, Medical Director of the Medical Consultant for Dialysis Patients Citizens Educational Center. And as many of you hopefully know, this August is Minority Donor Organ Awareness Month. And our goal is to really not only focus on getting more people to sign up to be organ donor, but also to educate them on living healthy, preventing disease amongst their friends and relatives, because we know that as the two leading causes of kidney disease and end-stage kidney disease are going to be hypertension as well as diabetes. And there are so many patients who may be facing issues with other family members having kidney disease. And so it becomes important to educate others on what it means to get checked on a regular basis. Kidney disease is silent and not many symptoms. Most people complain of fatigue, and that can be a symptom of so many other things. And so it's important to know your numbers. If you have high blood pressure, if you have diabetes, if you have underlying heart disease or have been on medications for a long time, such as non-steroidal for pain, chronic back pain, and you have taken Aleve, Advil, Motrin for many, many years, those things can actually affect kidney function and lead to chronic renal insufficiency or chronic kidney disease. So that becomes important to understand. So, hello, Nancy. Yeah, nice to see you here. And we really want to, there's a question from Nancy: what other illnesses can occur while on dialysis? Well, once you're diagnosed with kidney disease, for many patients, high blood pressure is not only a underlying cause of kidney disease, it's also a symptom of kidney disease. So many patients get diagnosed with high blood pressure, not because it's underlying, but because it's the manifestation of their own kidney disease. So that can be an issue. One of the things that happens while you're on dialysis is when you don't, or you stay on top of your fluid gains, you can advance your heart disease. So while you're in hemodialysis, it becomes important to understand that fluid balance or imbalance of your fluid, gaining too much fluid weight, can set you up for underlying worsening of your heart disease. And understand that if your underlying issues are diabetes and hypertension, you are going to have heart disease or issues with your heart just related to those two issues to begin with. Increasing fluid gains is going to weaken the left side of your heart, and that is going to contribute to, I would say, a less an ejection fraction, or the ability of your heart to pump well in a poorer manner, or lack the ability to do it as well as it was doing at 6 months on dialysis. The other thing you want to be able to understand is that for many people, we talked about this in the past, when you have your calcium phosphorus imbalance, once you begin to have stage 5 kidney disease, you'll start seeing some patients will have increase in the parathyroid hormone, increase in PTH, and that will worsen your bone disease. And that's usually what we call tertiary hyperparathyroidism. What it happens is that your parathyroids become autonomous, and they work on their own, not having anything to do with what your body's hormone level is. They just keep revving up and putting out. And for those of you who are on Sensipar, that helps control the parathyroid output, and so sensipars to, bring that back down to normal. If the sensipar doesn't work, you will need, your level gets extremely high, you will need to have 3.5 portions of your parathyroid removed, because it would lead to significant bone disease. So I think it's important to understand why it's important to keep your phosphorus in check, because that phosphorus, when it gets too high, is going to make your calcium levels abnormal, which is then going to rev up your parathyroid hormone, which is then going to cause increased PTH and more calcium deficit. So get educated. Nancy said, met someone last week who did not know that a kidney transplant can come from a cadaver donor. Please explain. There are two types of donors: a living donor, which is someone who is a friend, relative, or could just be an anonymous donor who wants to give one of their kidneys, because 98% of people are born with 2 kidneys, and you only need one to survive. So a living donor is a living donor kidney comes from someone who is living, taken to the OR once they cleared for kidney transplant, kidney donation. They're medically cleared by anesthesia, make sure they're good, and so that kidney is removed from that person once we demonstrate that they have enough kidney function remaining with that one kidney to do well. And kidneys enlarge over time if you're within a certain age, certainly if you're younger, but you do get enlargement of that remaining kidney to take over the function of your body and what your body needs. So that person, donor, is given up one kidney, the recipient receives that kidney. Cadaver donor or deceased organ donation occurs when someone is brain dead, have suffered a traumatic brain injury, either by trauma, a bleed, medications, and so what happens is that they end up with brain damage, because now the brain has suffered an insult and this cut off a blood supply to the brain, and so there's no demonstrable blood flow to the brain. The family is approached, and oftentimes the family can approach the medical professionals to say, I know that my loved one is not going to recover, and they're currently being maintained on this machine, which is to breathe for you and to get your heart rate going, but I want to donate their organs. Once an independent neurologist comes in and declares the patient has no brain function, either by a brain flow to the head, what we call a brain scan, or arteriogram to demonstrate that there's no blood flow, then the patient is declared brain dead, and they're still connected to the machine. So once the family agrees to organ donation, I feel this is the route they want to go, now that they're declared brain dead, then the OPO then comes in to decide what organs are viable to be removed, pending no infection, no cancer, no diseases that can be transferred. And so those are what we call deceased organ donors. They're taken to the OR, and whatever is agreed upon that can be removed is removed. The liver is removed, the heart's removed, the lungs are removed, the pancreas is removed. For some patients who are very young, the intestines can be removed to give to those who have shortcut syndrome. So one particular donor, and if the family agrees, you can also do tissue and long bones after, and they don't have to have a heartbeat to do that. Skin can be removed, tendons can be removed, and so many other, what we call, even for the eyes, the corneas can be removed. So those are all part of deceased organ donation, and the majority of transplants occur from deceased organ donation. Living donation, we want to increase those by educating people and their families and patients to know that you don't have to be related to donated organ to a loved one. You don't have to have the same blood type either. And you don't have to match perfectly. All you have to be is compatible with your other person who is in need. So if you're blood type O, I can give to anyone in need, whether they're blood type A, whether they're type B, or whether they're AB, because they will be always a universal donor. On the other hand, if I'm blood type O and I am a kidney recipient, I can only receive from a blood type O, and traditionally. But now we have these paired swapping, paired organ donation, paired matching, organ swapping, whatever your abbreviation is for it. And so your transplant center will put you into a pool where other patients and the donors are not able to give to each other, and so you have paired organ donor swap. Someone from Texas would give their kidney to someone in Minnesota, and Minnesota donor will go to someone else, and you can create a chain to be able to have many people benefiting from that chain reaction. But it starts out with those who are unable to have a living donor donate directly to them, and you have to have a potential donor that's cleared medically to enter the paired donor match. You cannot enter by yourself because you're getting a kidney from someone else, and so you have to find a source of kidney that you're going to give to someone else. And so that's the idea of paired organ donation, and those are generally for living donation. The other factor that also comes into play with deceased organ donation is direct organ donation. Person may not know you, but your loved one had an injury, they're declared brain dead, and now you're considering organ donation. Somehow you remember that at your place of employment, or maybe your job, or your church, that someone actually gave you information about their loved one, their child, or their cousin who is on dialysis in need of a kidney, and a light bulb goes off, and you say, "Why? Wow, maybe I can give one of my loved one kidneys to Mr. Johnson or Miss Franks over here," and they could be in another state. And so you pass that information on to the organ procurement organization. They check it out, they see whether they're compatible, see whether there's any contraindications, and if there isn't, someone benefits from a direct donation. They don't necessarily know you, but you were able to remember that that person is in need of a kidney transplant. And that is why it's also important to share your story if you're waiting for a kidney transplant, because you never know who might remember your story and will reach out to you in the event that a devastating brain injury occurred to one of their loved ones. So those are how we get to deceased organ donation, as well as direct organ donation for someone else. Why is anemia so detrimental to a renal patient? One of the things that happens is that your kidney makes erythropoietin, which is that hormone that allows you to make more and more red cells. With kidney function, that job goes away, and so anemia is a side effect of end-stage kidney disease. You no longer has that ability, and so you have to monitor your red cells, because if it gets too low, it affects your heart. If you have underlying heart disease, you need a higher level of hemoglobin to carry that oxygen, because you already have damaged blood vessels, which make it difficult to deliver oxygen, and now you're decreasing the amount of oxygen you're getting. So you would find that on dialysis, if you're on hemodialysis or any dialysis, you're going to get epogen shots or some synthetic form of erythropoietin to maintain your hemoglobin at a certain level, because with not enough hemoglobin not enough red cells, not enough hemoglobin, not enough oxygen carrying capacity, then leads to cell death or compromise of cell growth, cells to your brain, cells to your heart, and most importantly can contribute to, if your heart isn't getting enough blood and not getting enough oxygen, that's where you can suffer significant heart disease or even a heart attack. So that's important to keep check. And while you're on dialysis, for most patients, you try to keep your hemoglobin above 9. That's sort of like the critical point. Thank you so much for that question. Michael, that problem is that every hospital has different qualifications. I live in Utah. I qualified to donate in Iowa, but that means I have to fly across the country for numerous tests, yet my local hospital has denied me to donate. And that is true. But what I have seen is that, and yet each one has their policies depending on what they're comfortable with or what they feel your risks are to donation. Often donors are turned down because the nephrologists or the doctors feel that in your future or some years down the line, you may suffer a consequence of that donation. So make sure you understand that. But also, there are also some centers that are willing to do the workup for you for another hospital. And while they may not necessarily want you to become a donor, has denied you, the question is, there are things that could be done locally that would avoid you from flying back and forth. But when it comes to doing the cross match between you and a potential recipient, every center wants to do their own. They're really not trusting of another center. So in some instances, you can actually have that blood FedExed overnight to have your cross match done. In terms of blood work or looking at antibodies, those are things that they may consider mail in the blood overnight if they're willing, but that's a cost. So there are things. While I was in Alabama, there were patients who wanted to donate to another center, and so we would do that workup for them so that they would minimize the number of visits that they have for these numerous tests. Those are options that you can bring up, but again, it depends on who's going to pay for what, and will the hospital be able to recoup their costs for all the blood work or the tests that they're doing to work you up for another center. So that's an option, but not everyone may be willing to do that because it does require work and coordination and resources that they may not have to put forth, but it can be done. Just a thought. Thank you so much for that question. Please discuss self-cannulation. I'm going to punt on this because I am not a nephrologist per se, but self-cannulation, generally patients will have a good working fistula and graft, and they have to be taught how to do this and be done so it can be done in a supervised manner in a way that would allow you to minimize complications. So you will have to, if you're doing self-cannulation at home, you would be able to go through that training with a nurse in center dialysis to show you, making sure that you're able to do it safely, be able to connect to prevent bleeding, to know what to do in the event that the needles do not stay in place. You can have massive blood loss. So it is important for that person to be comfortable and okay doing that at home, especially if you're talking about doing it by yourself. And what are the steps you will take if something happens? So there's a particular amount of information that goes into that. You have to be willing to place those needles into your cannula, into your fistula, to cannulate your dialysis access so that you are comfortable. Many people are able to do it. They use their numbing medicine to make it less painful, the gel on top of the site, and are able to do it. But there are also many others who are like, no, I'm not doing that. So interesting, but I don't know anyone I know a lot of patients who are not willing to have it done, but we're happy having somebody else do it for them. Nancy reached out. I have lots of people that have videos showing self-cannulation. Thank you, Michael. I'm sure there's many things out there on YouTube showing you the right way to do it and how to avoid major complications, and also how to stop the bleeding in case something happens. Are patients limited to the amount of lists they can get on to receive a transplant? Not really. You can get on as many transplant lists as you are able to afford. The downside of that is that you have to be willing to travel to those transplant centers. So if you are multi-listing, the question is always, if they call you, how will you get there, and within what frame time? Do you have a plan set up to get there within a certain number of hours? And I'll make sure I'm on here. Sorry, got my back on the total amount of money you're going to be spending. But you want to be able to be connected to that center, because once you get transplanted there, that's going to be the one where you come back to get your biopsies to be cleared for making sure if your creatinine goes up, how you're going to travel back and forth the clinic over the first 6 months, whether you're seeing every other week or every once a month. What's the feasibility of getting back and forth, especially in that early time when you're not able to drive, or when you're on pain medicine and you're limited in going back and forth? What's your support system when it comes to that? So that's important to understand. And most people do that based on having relatives in another city that would allow them to get on that list again. So thank you for that question, Nancy. I see you're back on. Are there any other questions from the audience? Remember, this is my National Minority Organ Donor Awareness Month. We also want you to get involved in, usually within September, there's going to be a lot of kidney walks to raise awareness for organ donation. Be sure to reach out to your transplant center or your local organ procurement center, and volunteer, get involved, spread the word. Try to see whether or not you can join forces with your community center, your book club, anyone, to see how you can impact organ donation and how you can get involved with the group to advocate for more organ donation, and to bring awareness to kidney disease also, because it is a silent disease. And when you think about it, so many patients are not aware of they having kidney disease because it's silent. Educate others about your own disease process, as well as getting checked. Know your numbers, not just your cholesterol and your blood sugar, but also know your creatinine. Know whether you have protein in your urine. That's significant if you're not a diabetic, especially for young kids. There's a lot of glomerulopathies that outside of diabetes and high blood pressure that can cause kidney disease unknowingly. So a young teenager or someone in their early 20s who have significant protein in the urine, that should be a red flag. When your children or grandkids go to the doctors, make sure that they're getting their urine checked for protein. That's very, very important to understand. I see many kidney diseases miss, and because there was no structural issue wrong with the kidneys, they went to a urologist. The urologist said kidneys look good, no problem, but the loss of protein is an intrinsic problem to the kidney itself when nothing appears to be normal on the outside. So bear that in mind, and also educate those around you in terms of whether it's your community, your churches, and also be part of DPC Educational Center. And if you're not on the website, sign up for all the interesting information that comes out, whether it's a talk on Tuesdays, the phone chat, kidney chat, and get educated. Education is key, and that's important to remember. So I see there's no other questions. Zoom Roundtable every month. Check ads on Facebook and Instagram. If you're not on social media, be sure to go to DPC Educational Center website and on your phone as well, and you will be able to find all this information there about upcoming events. You'll also be able to find things such as good recipes to help you on your journey with kidney disease. There's a recent article on living with kidney disease, how to do fun things, how to not see kidney failure or being on dialysis as the end of the world, and you can still enjoy life. There are patients who go and I think there's cruises that you can go while on dialysis. My hubby has been on dialysis 4 years now, having problems with his phosphorus levels, and it's really about intake. So you want to minimize those foods that are high in phosphorus and stay on top of it. You also want to take your Foslo or those medications binders that they're giving you, that are giving him to lower his phosphorus level. If they're not working, there are also some new medications out that may benefit from that. So if he's been doing well for 4 years and now it's an issue, the question is what else can help him and what other resources or medications that are available that can keep that phosphorus down, because increasing phosphorus levels will cause increased atherosclerosis or calcium buildup in your arteries. And if you're waiting for a transplant, that can be detrimental. So it is important to make sure that you keep your phosphorus levels in check. I have seen patients who went from normal phosphorus and a normal x-ray to an x-ray 5 years later where all their blood vessels light up without contrast. That's just being able to see the calcium phosphorus metabolism taking effect within the arteries, and now they have severe atherosclerosis that can limit whether or not a kidney can be placed in the right or left lower quadrant. So what is a good source for a good diet for kidney health? Certainly, I would encourage you to go to DPC Educational Center website. They usually have lots of recipes on there. Other websites that are based on kidney function, such as National Kidney Foundation, American Kidney Fund, they usually have tons of things on there about how to eat well, how to avoid those kind of foods that will, where you can still have some fun, make some fun things with foods that are not high in phosphorus, and avoiding the dairy products and the cheese, and using a lot more plant protein based foods. So that is also an option. So thank you for that question. It's always important to support each other, and if there's websites or areas for any of you on here who know where good recipes are, be sure to post them. This will be also on the Facebook DPC site, so you can add more information to those who will receive, who are on Facebook, so that they be able to pass that on to other people. So I appreciate the question, and we're here to engage each other and to share, as you said, sharing is caring, health is wealth, and let other people know how to eat healthy. We all need to eat healthy, regardless whether we have kidney disease or not. But the goal is that for many of us, heart disease is going to be the #1 killer. So how do you keep your heart healthy? How do you maintain a good phosphorus level and keep it from impacting your vessel disease, so that if you're waiting for a kidney transplant, that you can still get a kidney transplant? What's the maximum amount of transplants one can receive? Generally, I've only done one patient with a 5th transplant. By then, your body have developed so many antibodies that it becomes more difficult to match or find a donor where you don't have antibodies to. Generally, each site can go twice. Once you have a kidney there, if it's taken out early, you can go and you generally rotate left and right sides to have the kidney. Oftentimes, if you're really scarred on both sides, you can put the kidney off in the middle and your abdomen. But for most people, we want to stay away from your intestines, or so that you're able to biopsy the kidney. What limits patients is the amount of antibodies they have accumulated by being exposed to previous donors. And with each donor transplant, you will develop antibodies to that previous donor. If you had a lot of rejection, you may have it. And so it's going to become even more difficult to get 1st and 2nd. Most people are able to get 3rd with maybe a minor difficulty, but that 4th transplant often takes a much longer time. And the health of the patient often can be much worse in terms of being able to accept a 4th transplant, and all the immunosuppression that goes along with it. Also, how old they are. They start at a young age. It's the years on dialysis that often will lead to more wear and tear on the body. So we try to tell folks it's better to get on the transplant list long before you need that transplanted again, so that you are still at the end of that first kidney but not really needing dialysis, but your function is less than 20%, you can get on the transplant list before you need to hit dialysis again. So those are important things to know. But thank you so much for all your questions. We've actually reached the end of this 30 minutes, and hope to see you next time. Take care, everyone. Be well.